Hello, this is Hallie Stephen-Castro, and I am going to do a brief lecture on peptic ulcer disease. This will not take place of your reading material, so make sure you do read the unit in Unit 13, the care of patients with stomach disorders, the peptic ulcer disease passage. Thanks. Okay, so just an overview of what peptic ulcer disease is. They're basically just little ulcerations or lesions within the mucosal lining. It can really occur anywhere up and down the GI tract, but they're just most common in the duodenum, which is that upper end of the small intestine. Our older clients, though, tend to get more gastric ulcers, and again, that typically happens at the lower end of the stomach. There is few people that have stress ulcers, but it was really more of a wide misconception that most ulcers were caused by stress. It's really very minimal that we've come to realize now. This occurs when that mucosal defenses become impaired due to a number of factors, and it just does not protect the lining of the stomach from the stomach acid or the hydrochloric acid. So then these ulcerations or these lesions appear, and that's what causes peptic ulcer disease. The conditions for gastric ulcers versus duodenal ulcers are a little bit different. So if you just want to kind of read that over a little bit, you don't have to go too deep into the pathophysiology, but just kind of review that. Again, the gastric mucosa is typically protected by that mucosal barrier. What they have understood now in the last several years that this primary cause of this breaking down is because of a little bacteria called Helicobacter pylori. They've also have a high correlationship to clients who are on long-term NSAIDs, any of those non-steroidal anti-inflammatory medications. So think about what clients might have to take these medications for chronic conditions. Again, they can affect anywhere from the esophagus, stomach, to that upper end of the duodenum. They can be very superficial or deep, and usually they're sharply demarcated, which you can see them pretty clearly on exam with a scope. Again, the etiology most often caused by that Helicobacter pylori. Risk factors, it's going to be the chronic H. pylori infection if it's a chronic infection. And it is pretty kind of a silent infection. They really don't have any other signs and symptoms until these ulcerations develop. And that's when they kind of go in and locate that, hey, by the way, they have Helicobacter pylori. Aspirin and NSAID use, ibuprofen, any of those NSAIDs, chronic long-term use can increase the incidence of peptic ulcer disease. There may be a familial pattern. Smoking is always discouraged. We think there is a higher relationship or a higher risk factor for those that smoke, as well as those with advanced age. Since the primary source is the Helicobacter pylori, and that is a bacteria, the prevention is key. Meticulous hand washing. It's not uncommon if it can occur within a family. We also recommend doing all the recommended food preparation to keep that bacteria from being transmitted from one person to another, because it can be transmitted from one person to another. All clients who have been started on long-term therapy for NSAIDs should possibly be tested as well, because if they already have the Helicobacter pylori and they get on the chronic NSAID treatments for some other underlying disease, it can heighten their risk for developing peptic ulcer disease. The clinical manifestations, it kind of depends on where the ulceration is, but the classic symptom is just abdominal pain, like a gnawing, burning, aching, hunger-like pain. Usually in the epigastric area, they may have some dyspepsia. That's usually for their gastric ulcer. It says relieved by eating. That's typically more with a duodenal ulcer, and it only happens immediately after eating, but then in about 90 minutes to a couple hours after the meal, then the pain does recur. So actually eating can make it worse for gastric ulcers as well as the duodenal ulcers. It's just immediately after eating that there might be a slight bit of relief with that. The presentation is less clear in older adults just because they're just a little bit more vague and nonspecific. Complications include hemorrhaging. If that break in the mucosal lining goes deep enough, it can cause the client to hemorrhage. So they would have an upper GI bleed. Another complication is a perforation, and that is where the actual lesion perforates through the stomach or through the abdomen. That is really a true kind of medical emergency, because if you think about that, all that content in the stomach or in the duodenum is basically leaking out into their cavity, into their abdominal cavity. There are some specific assessment pieces I want you to know about that. If they have a perforation, typically a client will have a very rigid board-like abdomen, very hard, and has some rebound tenderness and pain. So that would be a true medical emergency. One of the other issues it can cause is a gastric outlet or pyloric obstruction. That's usually with a gastric ulceration. And again, there's some little bit more information and detail in your book if you want to read additionally on that. There is a disorder called the Zollinger-Ellison syndrome. They have these gastromas or these tumors that will cause increase in gastrin as well as increase in acid production. That puts them at higher risk for developing peptic ulcer disease as well. But it is a very rare disorder, so it's very, very rare. Some of the diagnostic tests that they will do for peptic ulcer disease includes an upper GI, especially if they suspect that a perforation has happened. They need to do a plain radiograph or plain x-ray first, either of the chest, abdomen. They can call it an upper GI or a KUB, which includes kidney, ureters, and bladder. They will do those x-rays to see if there's any type of what they call free air or free fluid floating around into the abdominal cavity, especially if they suspect perforation. In EGD or gastroscopy, that's the scope, the upper GI, the scope. A biopsy, if they're able to do a scope, frequently they'll take a little sample of the specimen and test it for Helicobacter pylori. There's other non-invasive testing that they can do for Helicobacter pylori as well without having to do the whole scope as well. If that rare disorder, that Zollinger-Ellison syndrome, they may do some additional gastric analysis if they suspect that that's the underlying cause. If there results in a GI bleed, they may have to go do a bleeding scan or some other additional test within nuclear medicine to find the source of the bleeding. Surgery is not too often. It's not too often or too frequent with Helicobacter pylori. If there's a perforation, they may have to go to surgery if they have that serious complication. Medication therapy or pharmacologic therapy. I know they should have covered some of these in pharmacology already. But if it's due to, it kind of have to look at what the cause of the ulceration is. If it's due to Helicobacter pylori, we need to kind of address that. If it's due to NSAIDs, well, then they need to address that. So if it's due to Helicobacter pylori, there's usually a two medicine combination that they'll give, either the chloromethyricin, amoxicillin, and a PPI, which is a proton pump inhibitor, or they may choose to give the bismuth subsilicate, which is Pepto-Bismol, and tetracycline and metronidazole, which is also known as Flagyl, plus the PPI. So typically, and it may vary from place to place, but those are two of the common medication combos that they'll give for Helicobacter pylori. If it's due to NSAIDs, well, we need to try to discontinue them if possible, or have the client have them discontinued. If they are unable to, due to whatever chronic condition they take it for, consider doing a lower dose with maybe twice a day, and also consider adding in a PPI or that proton pump inhibitor to help reduce the acid in the stomach. There's also some medications called mucosal barriers, which help kind of protect the lining of the stomach. Carafate or sulcarafate is a big one. There's bismuth compounds, which again is like Pepto-Bismol and those types of medications, antacids, and some prostaglandin analogs. Ideally, we'd like them to maintain good nutrition. Bland or restrictive diets are no longer necessary, although your book does go into about kind to reduce the amount of acidic foods that client eats. Mild alcohol intake is not harmful, but we still want to discourage that, as well as smoking cessation. For your noticing, if we're talking about the clinical judgment model, for your assessment, you need to identify symptoms or identify clients who may be at risk. If they have a family history of H. pylori, well, then there's a chance that the client may also have H. pylori due to its mechanism of transmission. Other things included in the history is the health history, the complaints of pain, where are their pain located, is it abdominal, is it epigastric, what type of relief measures, does it get worse after eating, does it get better immediately but then get worse. You just kind of have to do a more focused history on their discomfort or abdominal discomfort, and what medications they're taking, if they have a history of chronic NSAID use, cigarette smoking, or alcohol use. Just general appearance, and make sure you do a thorough abdominal exam and obviously assess your vitals. If they do have these peptic ulcer disease, just to see if it has an impact on their disease, of their lifestyle, family members, leisure activities, because it can be very discomforting, especially with some meals. Evaluate the impact and have them make appropriate lifestyle changes. So if you analyze some of that data that you've collected with your nursing process, then we can see that, hopefully kind of narrow down which clients might be at higher risk for peptic ulcer disease or might be need a referral to a provider. For clients who have peptic ulcer disease, again, it's managing that pain with drug therapy, nutrition therapy, and any other complementary therapies that might be prescribed by the physician with who we're collaborating with. If they have some upper GI bleeding, there may be some non-surgical management of that, as well as surgical management of that, depending on the severity and location of the ulceration. If they're able to go home, which they should be, most clients, it's not too severe unless they have a perforation, and then they might have to be a surgical candidate. But I did assist them with some home care management on how to manage their disease and how to take medications appropriately, and a lot of medication administration and medication education, and any type of resources they may need. They may need to follow up with a GI doctor. Just some other nursing interventions that you can use with peptic ulcer disease. Just monitor the stools for gastric drainage for any type of blood, and make sure you know the medical terminology for the exam. Hematemesis, hematochezia, melena, those types of terms, because typically we're going to use those medical terms on your exam. If they have an IV, you're going to maintain that IV therapy to make sure they have sufficient fluid volume. If there's an NG in place, we need to make sure it's in the proper area and it's patent. Monitor the hemoglobin hematocrit if they're at risk for GI bleed, or if they've had a GI bleed. Also monitor the electrolytes, as well as the BUN and creatinine levels. Again, if they're worried about fluid volume deficit because of a potential bleed, they may have volume issues, perfusion issues with the kidneys. For the abdominal assessment, you'd want to assess that at least every 4 hours and record your findings. Make sure you maintain bed rest with the head of the bed elevated to kind of promote gastric emptying, and always ensure for the client's safety. Help them manage their pain, help them assess their pain, location, type, severity, using your PQRST mnemonic or whatever pain mnemonic that your facility that you're working at is using. Administer those PPIs and medications as ordered, and make sure if they're due before meals that they get there before they eat their meals to give them time to work. Teach those relaxation techniques, stress reduction if the ulcerations are due to stress, and any other lifestyle management techniques. More information about rest. I'm going to kind of go through some of these a little fast. But again, we want to emphasize the importance of taking medications and taking them as when they're due, and if they're on the antibiotics, make sure they complete those antibiotics if it's related to a Helicobacter pylori. Make sure that they limit their food intake after an evening meal, just kind to smaller, more frequent meals. Encourage, and again, those relaxation techniques. If they're having some nutrition issues, we need to address those nutrition issues, assess their diet, refer to a dietitian if necessary, monitor for lack of eating or unable to have any gastric emptying, because that could be a potential complication, any nausea and vomiting. And of course, you're going to monitor any of the lab values related to anemia because of possible hemorrhage and any other nutritional deficits. Hopefully, on evaluation, that your client will not have any peptic ulcer disease or complications. If they have, hopefully they'll be able to verbalize pain control or relief, and they can adhere to their medication regimen and their lifestyle changes, that and have no experience or does not have any evidence of a GI bleed. And I think that is the end of that. I do have a series of questions that I will present to you, and we'll do that on a separate PowerPoint. Thanks.